Hi, I'm Brittany, a neurodivergent mum and speech pathologist. This is Not Just Theories, where I share what actually works in my real, messy life. Because life doesn't follow a theory. Here's what I actually do. Hello, everyone, and welcome back to Not Just Theories. This will be the third episode in the series that I'm doing at the moment on infant sleep. If you missed it, in the first episode, we talked about circadian rhythm and the power of a consistent wake time, about how anchoring the day can help build sleep pressure naturally. In the second episode last week, we talked about sleep needs and how a huge amount of sleep distress comes from expecting children to sleep more than their bodies actually require. I shared some strategies about how to investigate your child's unique sleep needs and consider how to best meet the needs of everyone in the family and how to distribute that sleep across 24 hours. Today, I want to talk about another really important piece of the puzzle, which are the medical and biological barriers to sleep. Because sometimes sleep is hard, not because of routines or habits or parenting choices, because something in the body is making sleep uncomfortable or fragmented or physiologically difficult. And when that happens, behavioural sleep advice is like pushing a rock uphill. It's a complete waste of time. And I think it's one of the most frustrating things that parents can encounter when they seek help with sleep is being told that the sleep problems are behavioural, because although sometimes they are not always. So if a child is waking frequently because they can't breathe comfortably, or they're experiencing reflux pain, or their iron levels are low, or their nervous system is wired differently, or their gut is reacting to something they ate, the problem is not behaviour, it's biology. And biology needs investigation, which sleep schedules and sleep hygiene and sleep training do not fix. And this can be really tricky because a lot of the medical barriers to sleep can be quite subtle, particularly in infants where they do not have the ability to communicate how they're feeling. And a lot of these barriers don't show up as dramatic illness. There are a handful of medical barriers to sleep that are extremely apparent from very early on, but most of those are picked up straight away. And it's the subtle things that cause frequent night waking or restless sleep or early morning waking or lots of movement during sleep, things like snoring and mouth breathing or needing physical contact constantly to settle. And so many of those things are interpreted as habits rather than physiological signals that something is not quite right. So one of the biggest sleep disruptors in young children is breathing difficulty during sleep. So that can be related in the early weeks to sort of all the mucus that's still in the respiratory symptom. But beyond that, it can be related to things like enlarged adenoids, enlarged tonsils, fluid in the ears, other kinds of nasal obstruction. Even really mild breathing disruption can fragment sleep significantly. If breathing is not smooth and easy, then the brain stays more alert. So often children experiencing these will toss and turn and they will wake frequently and they will sweat heavily at night and they will snore or breathe through their mouth and wake exhausted, even if they've spent a long time in bed. And some children with sleep disorder breathing can actually appear hyperactive or wired. So this is maybe for older children because that fragmented sleep affects their nervous system. Some children with sleep disordered breathing are diagnosed with ADHD, and when the sleep disorder breathing is treated, they no longer show signs of ADHD. And this is one of the reasons I talk so much about ENT issues in my work with families, because the sleep problem can actually be an airway problem. I talked more about it in my episode a few weeks ago about ENT issues. I really recommend going back and listening to that if that's something that you think is relevant to your child. Another really common biological barrier to good nights of sleep is reflux, because reflux causes pain when you're lying flat. So it can really cause a lot of frequent waking, back arching, clear discomfort and squirming. That baby might need to be settled upright and then wake up as soon as you place them down on their back to sleep, which is obviously that safe position, which we're all encouraged to do. So you might, if your child is suffering from reflux, you might find that they sleep better when they're held upright or when they're rocked or when they're kept close to a caregiver, partly because of the position of their body. Sometimes children who suffer from reflux also will want to feed very frequently because having that milk actually settles the reflux, but it's that little bit of a spiral where having those really regular small meals can actually be misread as causing the sleep issues. So sometimes this is something that you go to the doctor and you say, my child is waking regularly, and they say, how often are they feeding? And you say, well, every time they wake up. And they're like, well, if you're feeding them every 45 minutes, then that's what's causing the discomfort. And it's like, well, is it? Or are they wanting to feed every 45 minutes because they're in pain? And particularly breastfeeding might be quite soothing for that child and help them feel a little bit better. And that little bit of milk helps sort of settle the reflux for a short period of time. So this reflux causing sleep issues is often interpreted as something like a sleep association issue where the child is associating being fed to sleep with going to sleep. But it's actually because certain positions are more comfortable for their body, and that regular feeding is actually soothing the underlying reflux symptoms. So although back arching can be associated with the ENT symptoms that I just mentioned, they can be a really strong indicator of reflux. Reflux can be silent in that, you're not seeing huge amounts of other symptoms, but if your child's sleep is disrupted, it might be worth discussing with your provider whether or not trialing some sort of reflux medication might be beneficial. So it's something I really, really wish we'd tried it with my daughter, because we did it with my son and it made a huge difference. And he was so similar to her in some of the ways he slept. And I actually did ask a few times whether it might be reflux. And every time my GP said, no, I don't think so. Because, she had allergies and CMPI and other things. And they were like, well, that's the cause of the reflux. So we'll treat that and it will fix everything. It didn't. I wish we'd also tried medication because it made a huge difference for my kid. So yes, while reflux medications can have side effects, if your child is not getting enough sleep and you are not getting enough sleep and your mental health is tanking, consider whether asking about trialing a reflux medication for a short time might help you either eliminate it as a factor or find out that this was one of the causes for your child. Another factor that doesn't get talked enough about in baby sleep conversations is iron, because low iron levels can contribute to restless sleep and frequent waking and symptoms similar to like restless leg syndrome and increased movement during sleep. So because iron is really deeply involved in dopamine regulation as well, and that affects how the nervous system transitions between sleep stages. So for some children, improving their iron levels can make a really noticeable difference to sleep quality. And some children have a lower iron store for a whole bunch of reasons. So if the maternal iron store was low during pregnancy, or for some reason, if there was, issues at birth and that child wasn't able to have delayed cord clamping, that can affect their iron stores. Once the baby's past sort of 4 to 6 months, if they're not eating high iron fortified foods, then that's when their iron levels can often start dropping. So there's a few different things that can contribute. And sometimes it's not about their intake. My second born, he's always been like an absolute carnivore. Honestly, I've seen him eat like half a rotisserie chicken in one sitting. He's only 18 months old. He's eaten 3 steaks in one sitting, like 3 full-size steaks. Like he eats a lot of meat and always has. And we used to think that meant that iron wasn't an issue because he had so much in his diet. But actually in hindsight, he got an iron test done when he was 12 months old and his levels were really low. It was quite surprising because he was so focused on eating meat, but the reason he was probably doing that was because his iron levels were so low and his body was craving that meat. So your child may not be consuming enough in their diet, which could cause low iron. But even if it looks like your child is eating enough iron-rich food, is that because their iron stores are super low and their body is craving it? Something to consider. I would absolutely not recommend trying iron supplementation though without a blood test to show what your child's iron levels already are, because iron medication can actually be quite risky if it's not needed. So absolutely something that you need to do a blood test before you supplement with iron. Definitely something to ask about though. Look, and a lot of doctors are really reluctant to do blood tests on children and infants because it can be quite distressing. The younger they are, in a sense, the easier it is, because although they're tiny, they fight it a little bit less, especially the first time. But for both of my kids, their blood tests that they've had have been really incredibly useful at helping us figure out what was maybe lacking in their diet. And for both of them, iron was one of them. And so, look, my iron levels have always been really borderline during pregnancy, but never enough that I've needed anything other than some supplementation. But I've always wondered, like, that, you know, it's borderline, it's okay, but was it really high enough for my child? So something to consider if you've had any iron issues in your life is whether or not your child might be experiencing some low iron, and that might be impacting on their sleep. Something else that those blood tests found for both of my kids was low vitamin D. Again, that's another biological factor that is connected to sleep and regulation because it plays a role in immune function and inflammation. So low vitamin D doesn't automatically cause sleep issues, but if the levels are low, it can be part of a bigger picture affecting their health and their regulation. Another medical contributor to poor sleep can be food allergies or sensitivities. One of the most well-known examples in infants is something called cow's milk protein intolerance or allergy, sometimes called CMPI or CMPA. And that kind of allergy can cause like gut discomfort, reflux symptoms, unsettled sleep, frequent waking. So this is different. Some allergies are what we call IgE mediated, and they show up quickly. So those are your classic, like, you know, rash or hives, and the kind of reaction that might lead to anaphylaxis. So they're a more well-known type of allergy, but most commonly in infants, this cow's milk protein intolerance or allergy is called a non-IgE allergy, which means that the symptoms can be slower and harder to recognize because it more resembles like a celiac reaction. So it's a gut reaction, and it takes a lot longer to kick in. So instead of kicking in within 1 to 2 hours of eating, it's often more on the sort of 3 to 16 hours before symptoms might occur. It can cause, so one of the early symptoms is often that reflux or lots of spewing up. It can cause things like constipation or diarrhea in infants. It can cause bleeding in the gastrointestinal symptoms. So, you know, you might see some specks of blood or large amounts of blood even in your child's nappy alongside their poos. So there's a lot of things that you can see. I'm going to talk heaps more about these in a later episode because it was a big topic on its own for our family. And another biological component of sleep are sensory differences and neurodivergent nervous systems, because some babies experience the world more intensely than others. So their nervous systems might be more highly alert. They might be more easily overstimulated, so they might be extra sensitive to sound or light or touch. And these differences can show up very early and are sometimes early indicators of neurodivergence. So every child who is later diagnosed as being autistic was an autistic baby once. And there are other types of neurodivergence that can show up with different sensory needs as well. So, you know, autism's not something that starts at a particular point. And I think often parents find out at the age of 1 or 2 or 4 or 8 or 34 that their child was autistic. And all of a sudden there's all these early indicators that are then explained by that. And so that can lead to one of two directions, those sensory needs. So it might mean that they need more movement or more proximity. They need to be touching someone to fall asleep, and they need the warmth and they need that movement. And so they might be sensory seeking, or they might be quite sensory aversive and they need really specific sensory environments. They might need a really dark room. They might need white noise or no white noise, or they might need windows shut or windows open, or they might need the room to be really cool, or they can't sleep on the go. So it could go either way, these extra sort of sensory needs. So again, I'll explore that more in a future episodes because I think this deserves its own discussion. So, you know, those are a summary of some of the medical and biological contributors to poor sleep. But knowing that they exist is one thing, and getting help for them is another thing entirely. And a lot of parents run into barriers when they try to investigate these medical possibilities. And this happened to me. When my first child was experiencing severe sleep disruption, I was at the GP all the time. I was there almost every week for months and months and months because it was such a big issue for us. I asked about iron studies. I asked about seeing an ENT and trying to find out why the sleep was so fragmented. I asked about reflux medication. And I was continually told that I couldn't pursue those referrals until I had completed a residential sleep training program, even though I didn't want to do that. It wasn't something that aligned with my parenting values. So even though my concern was that something medical might be causing the sleep problem, the medical professionals I was seeing weren't willing to investigate that until behavioural causes had been eliminated. The system expects behavioural intervention before medical investigation, which just did not make sense to me at all, because why would I let my child cry out for me and not go to them when they were crying out to me because they were in pain, because their biology was preventing them from, linking sleep cycles? And why would I respond to that behaviorally if it's caused by a medical issue? I think the order should be the other way around. You should medically investigate the causes for sleep before you even think about behavioral interventions. So it made no sense to me, and it took a lot of fighting before I was able to get those addressed. So in the end, even though I was from, honestly, the 2-week check, I was asking about reflux, and we then figured out the allergies at about 8 to 12 weeks, and we were hoping that was when we started getting longer stretches of sleep. We were doing some behavioral things that I've talked about in previous episodes. Sleep was getting a little bit more manageable, and I kept asking and kept asking and kept asking. And finally, at 18 months of age, we were referred for a hearing test, which showed hearing loss. And then we went and saw the ENT, and my child had enormous adenoids, and we did the surgery for that. And the day that she went under for the surgery on the adenoids and the insertion of the grommets, we did a blood test because she was already under anesthesia. And we found out that there was low iron and low vitamin D also contributing. So all these things at 18 months old that I had been asking about for close to 18 months. Like, what kind of behavioural intervention can fix enlarged adenoids? Nothing. What kind of behavioural intervention can fix low iron? Nothing. If your child's sleep difficulties are being driven by biology, behavioural strategies cannot solve the problem. You might see temporary changes. Your child might stop waking you up, but that underlying discomfort or that disruption will still be there. So I don't want anyone to listen to this and then feel anxious or assume that something is wrong, but I want you to stay curious about it and ask questions like, is my child breathing comfortably during sleep? Are they snoring? Are there signs of reflux or discomfort? Are they restless at night? Are there feeding concerns or allergy concerns? What kind of sensory supports does this child need to fall asleep? Because those questions will help you advocate for your child and guide your conversations with the healthcare providers that you're working with. And I've spoken about advocacy before. It requires persistence. So again, even for professionals like me, it took me multiple attempts to be heard. And so my instincts were saying that something wasn't right. And it took me a long time to get somebody else on board. And we finally found an amazing pediatrician who sort of took us under her wing, and we sorted it all out, and we got to the point where sleep is manageable. So we got there, and it was a combination of some behavioural things and some medical things. But we will never know to what extent those behavioural issues started because of biological needs. If those behavioural issues, reflux, low iron, adenoid issues, had been sorted at 4 or 5 or 6 months of age, then would those behavioural issues that we lent into, things like the late sleep-ins or trying for too much sleep, would they have made as much of an impact as they did? Because the reason we were letting her sleep in and not doing that consistent wake-up time was because she was sleeping so poorly. So it was this horrible cycle. And I just want everyone to think about whether or not the sleep issues that your child might be having could have a medical component. So not every sleep problem is medical. Most children have phases of sleep disruption that are completely normal, whether it's when they're teething or when they're learning a new skill or when they first sort of are figuring out those more adult sleep cycles rather than infant sleep cycles at that 4-month point. So I just want everyone to consider, though, can you consider biology first and behavior last, rather than jumping straight to a residential sleep program that encourages a parent to ignore their instincts to respond to their child when their child is in need? The only way your child can ask for your help when they're an infant is to cry out for you. And, ignoring that when you haven't found out why they're crying out for you just doesn't sit right. So in future episodes, I will talk a little bit more deeply about some of the specific topics that I touched on today, including the allergies and food sensitivities and the sensory needs and neurodivergent sleep patterns, because I think it's a whole system, and understanding that whole system is how we eventually got sleep under control. Figuring out the biological components, figuring out some of the behavioural changes or schedule changes that we could do alongside that. And now sleep feels like it's really much more manageable in our family. So I hope today's been helpful. If for nothing else, it helps you understand that you might not be doing something wrong, and understanding can take time to uncover, and persistence and advocating for your child and figuring out what is making sleep so hard for your particular child is really important. I look forward to talking to you next week some more about sleep. It's one of the topics I'm most passionate about, because it's what I think about most of the time. And I hope this has been helpful. Talk to you soon. Thanks so much for listening to Not Just Theories. I really appreciate you being here. If this episode resonated with you, the best way to support the show is to follow, leave us a rating or review, or just share this episode with someone else who you think might find it comforting or useful. I hope to see you back here soon.